10 Early Pancreatic Cancer Symptoms Most People Miss. Every year, hundreds of thousands of people worldwide receive a diagnosis of pancreatic cancer. For many, however, the disease is discovered only after it has already reached an advanced stage. Unlike some cancers that can be detected earlier, pancreatic cancer often develops quietly, with few noticeable warning signs in its early phases. Even with major progress in cancer research and treatment, pancreatic cancer remains one of the leading causes of cancer-related deaths globally. A major reason is its ability to progress silently, sometimes for months before symptoms become obvious. The pancreas itself is an extraordinary organ located deep within the abdomen, behind the stomach, and closely linked to the small intestine. It plays an essential role in the body by producing digestive enzymes that help break down food and hormones that regulate blood sugar levels. Yet its hidden position presents a challenge. Because it sits so deep inside the body, tumors can grow unnoticed for long periods before they are detected. Historically, pancreatic cancer has been diagnosed most commonly in people around the age of 70. However, recent studies suggest a concerning trend. Cases among younger adults may also be increasing. In this video, we'll examine 10 important signs and symptoms that can be associated with pancreatic cancer. We'll also explore the biological processes behind these symptoms and explain why recognizing these warning signs could contribute to earlier medical evaluation and potentially earlier diagnosis. Disclaimer: the information provided about pancreatic cancer is intended for general educational purposes only and should not be considered medical advice, diagnosis, or treatment. Symptoms, risk factors, and treatment options can vary between individuals. Always consult a qualified healthcare professional for personalized guidance regarding any medical concerns or decisions. All information presented has been thoroughly researched and verified. You can find source links in the video description. 1. Prodromal depression and anxiety. Here is something that surprises most people. Pancreatic cancer can affect your mind before it ever causes physical pain. Research shows that between 33% and 45% of pancreatic cancer patients experience new-onset depression or anxiety, and this happens on average 6 months before any classic physical symptoms appear. In some documented cases, these psychiatric symptoms surfaced 1 to 2 years before diagnosis. This is not coincidental, and it is not simply the psychological response to being sick. Scientists believe this is a paraneoplastic effect, meaning the tumor itself is altering brain chemistry through the immune system. Specifically, pancreatic tumors secrete pro-inflammatory cytokines, including interleukin-6 or IL-6, which cross into the central nervous system and disrupt serotonin and dopamine regulation. This is a biological process driven by the cancer itself, independent of emotional stress. What makes this sign particularly critical is its timing. When a previously mentally healthy adult develops unexplained, new-onset depression or anxiety, with no clear life stressor and no prior psychiatric history, this should prompt a broader medical evaluation, not just a prescription for antidepressants. Clinicians and patients alike need to understand that in some cases, the mind is sounding an alarm that the body hasn't yet learned to verbalize. This early warning deserves to be taken seriously. 2. Palpable gallbladder. Courvoisier's sign. In most clinical encounters, a palpable gallbladder is an abnormal finding. The gallbladder is tucked beneath the right lobe of the liver, and under normal circumstances, it cannot be felt through the abdominal wall. When it becomes enlarged enough to be detected on physical examination, particularly in a patient who is also jaundiced, it carries a name, Courvoisier's sign, and it has been associated with malignant biliary obstruction for over a century. The physiological reasoning behind this sign is elegant and important. When the common bile duct is obstructed by a gallstone, the gallbladder is typically scarred, fibrotic, and chronically inflamed from prior episodes of obstruction and infection. It cannot distend significantly, but when the obstruction is caused by a tumor, growing slowly and steadily, the gallbladder has not undergone that prior inflammation. It remains compliant, and as bile backs up progressively behind the growing tumor, the gallbladder distends quietly and painlessly until it becomes large enough to palpate. The sign has moderate to high specificity for malignancy but lower sensitivity, meaning its presence strongly suggests cancer, but its absence doesn't rule it out. In practice, Many tumors produce obstructive jaundice without producing a palpable gallbladder, because imaging often identifies obstruction before the gallbladder reaches a palpable size. What Courvoisier's sign offers, when present, is a concrete, bedside detectable clue that deserves immediate imaging follow-up. A painless, enlarged gallbladder in a jaundiced patient should be considered a malignant obstruction until imaging definitively proves otherwise. 3. Steatorrhea and exocrine pancreatic insufficiency. The pancreas has two primary functions: producing hormones like insulin and glucagon, and producing digestive enzymes that break down fats, proteins, and carbohydrates. When a tumor obstructs the main pancreatic duct or destroys enough functional pancreatic tissue, those enzymes stop reaching the small intestine in adequate amounts. The result is a condition called exocrine pancreatic insufficiency, or EPI, and one of its most telling signs is a specific type of stool called steatorrhea. Steatorrhea is not just loose stool or an upset stomach. It is distinctly fatty, pale or clay-colored, bulky, foul-smelling, and it floats or sticks to the sides of the toilet bowl in a way that is difficult to flush. This happens because undigested fat is passing through the entire digestive tract without being absorbed. Patients often notice the change in stool appearance weeks or months before they seek medical attention, dismissing it as a dietary issue or irritable bowel syndrome. The critical distinction here is that this is not simply a gastrointestinal inconvenience. Fat malabsorption leads to deficiencies in fat-soluble vitamins, specifically vitamins A, D, E, and K, which over time can impair bone density, immune function, vision, and clotting ability. When steatorrhea persists without an obvious dietary explanation and is accompanied by weight loss or jaundice, pancreatic imaging is clinically warranted without delay. 4. Enlarged liver and fever with chills. Two signs that often appear together in advanced pancreatic cancer deserve to be understood as a connected picture: hepatomegaly, an enlarged liver, and unexplained fever with chills. Hepatomegaly in this context typically signals that the cancer has spread to the liver through the portal circulation. The liver is the most common site of pancreatic cancer metastasis, and as tumor deposits grow within the hepatic parenchyma, the organ enlarges and can often be felt several centimeters below the right costal margin on physical examination. In patients with concurrent jaundice, a firm, enlarged liver combined with a distended gallbladder creates a clinical picture that is highly suggestive of malignant biliary disease. Fever with rigors, the kind involving shaking, chills, and temperature spikes, introduces a different mechanism. The most common cause in this context is cholangitis, a bacterial infection of the obstructed bile duct. When bile cannot drain freely due to tumor obstruction, it becomes stagnant and prone to colonization by gut-derived bacteria. The result is ascending infection that produces the classic Charcot's triad of fever, jaundice, and right upper quadrant pain, though the pain component may be muted in cancer patients. Less commonly, tumor-related systemic inflammation can generate low-grade fevers through cytokine release, independent of any active infection. Distinguishing infectious from paraneoplastic fever matters clinically because they require different interventions, antibiotics and biliary drainage for cholangitis, versus a different management approach entirely for inflammatory tumor fever. 5. Itchy skin, pruritus, without a rash. Pruritus, generalized itching, in the context of pancreatic cancer is a direct consequence of bile duct obstruction, and it often emerges alongside or just before visible jaundice. When bile cannot drain normally, bile salts accumulate in the bloodstream and eventually deposit in the skin. These bile salts irritate cutaneous nerve endings, producing an intense, diffuse itching that has no visible rash, no allergic trigger, and no topical remedy. The itching is frequently worst on the palms of the hands, the soles of the feet, and the extremities, though in severe cases it can involve the entire body surface. Patients describe it as a deep, crawling sensation that antihistamines barely touch. Unlike eczema or a contact dermatitis, scratching provides no relief. If anything, it worsens the skin's integrity without addressing the underlying cause. What makes cholestatic pruritus clinically distinctive is its relationship to the other biliary symptoms. When a patient reports itching alongside dark urine, pale stools, or yellowing of the eyes, the cluster points unmistakably toward bile duct obstruction. In isolation, however, Pruritus can be mistaken for dry skin, a dermatological condition, or an allergic reaction, especially in the weeks before jaundice becomes visually apparent. The mechanism isn't entirely reducible to bile salts alone. Research also implicates endogenous opioids and lysophosphatidic acid in cholestatic itch, which explains why some patients experience relief from opioid receptor antagonists. But regardless of the precise mediator, the clinical message is clear. Unexplained whole-body itching without a rash demands a look at liver and biliary function. 6. Abdominal swelling and ascites. The abdomen is not supposed to contain free fluid. In health, the peritoneal cavity, the space that houses the digestive organs, contains only a minimal lubricating layer. When pancreatic cancer spreads to the peritoneum, or when liver metastases create enough disruption to cause portal hypertension, fluid begins to accumulate in that space in significant quantities. This is ascites, and it can build up to several liters before it becomes unmistakable. The presentation is a progressively distending abdomen, firm, often symmetrically rounded, sometimes described by patients as feeling bloated all the time regardless of eating habits. Clinically, physicians detect it through percussion. Tapping across the abdomen produces a dull sound over fluid areas and a hollow sound over air-filled bowel, a finding called shifting dullness. Ascites in the context of pancreatic cancer carries serious clinical implications. It typically indicates either peritoneal metastasis or significant liver involvement, both of which place the disease in an advanced stage. The fluid itself contains tumor cells in some cases, and its accumulation creates a hostile environment for the abdominal organs, compressing the stomach, the kidneys, and the diaphragm simultaneously. The discomfort is often significant. Patients describe difficulty breathing deeply because the diaphragm cannot fully descend, an inability to sleep flat, and constant pressure across the midsection. Some patients initially attribute the swelling to weight gain, which delays recognition. When an abdomen grows larger while the rest of the body loses weight, that paradox deserves urgent clinical attention. 7. Feeling full quickly, early satiety. Imagine sitting down to a meal you used to finish without effort and finding that after a few bites, you feel uncomfortably full. Not, I should stop eating full, but I physically cannot continue full. This is early satiety, and in the context of pancreatic cancer, it has several distinct mechanisms working against normal appetite simultaneously. A tumor in the body or tail of the pancreas can press directly on the stomach wall, physically reducing its capacity to expand. When the stomach cannot distend normally, stretch receptors in its lining signal fullness almost immediately after eating begins. This isn't a psychological relationship with food. It's a mechanical constraint imposed by something pressing from the outside. Ascites, which we'll discuss separately, compounds this problem dramatically. When fluid accumulates in the abdominal cavity, it compresses the stomach from multiple directions at once, reducing effective meal volume to a fraction of what it should be. Patients sometimes describe it as wearing a tight belt around their midsection that they cannot remove, one that tightens further every time they try to eat. Then there is the exocrine insufficiency layer. Even when a patient manages to eat, impaired enzyme output means that food sits in the upper GI tract longer than it should, creating a persistent sense of heaviness and fullness between meals. The result is a cycle where patients eat less, absorb less, and lose more weight, often rapidly. Early satiety may seem like a benign inconvenience, but when it appears alongside other symptoms on this list, it becomes a meaningful piece of a dangerous pattern. 8. Dark-colored urine. You use the bathroom dozens of times each week, and almost nobody pays close attention to what ends up in the toilet. But the color of your urine is one of the most direct windows into what's happening inside your body, specifically inside your liver and bile system. When urine turns a deep amber, brown, or dark tea-like color, especially if you're well hydrated, that's a biochemical alarm worth taking seriously. What's happening is this. Your blood contains a yellow pigment called bilirubin, a byproduct of the normal breakdown of red blood cells. Under healthy conditions, bilirubin moves from the blood into the bile duct, travels to the intestine, and exits the body through stool. But when a tumor develops in the head of the pancreas, which is the most common location for pancreatic cancer, it can press directly against or grow into the bile duct, physically blocking that pathway. Bilirubin has nowhere to go. It backs up into the bloodstream, circulates throughout the body, and eventually gets filtered by the kidneys, which is why it starts showing up in your urine, turning it that unmistakable dark color. This symptom often appears quietly, before pain sets in, and before jaundice becomes visually obvious. It's frequently the body's first visible protest. If your urine has been consistently dark for several days and you're drinking plenty of fluids, don't chalk it up to diet or dehydration. This is the kind of change that warrants a conversation with your doctor soon. 9. Jaundice. Jaundice is one of the most recognizable and clinically urgent signs associated with pancreatic cancer. It appears as a yellowing of the skin and the whites of the eyes, called scleral icterus, and it occurs when bilirubin, a byproduct of red blood cell breakdown normally processed by the liver and excreted through bile, backs up into the bloodstream. In pancreatic cancer, the most common cause is a tumor in the head of the pancreas obstructing the common bile duct, which runs directly through or adjacent to that region. The obstruction prevents bile from draining into the small intestine. Bilirubin accumulates in the blood, deposits in the skin and conjunctiva, and also spills into the urine, turning it the color of dark amber or cola. At the same time, stools may become pale or clay-colored because bile pigment is no longer reaching the intestine. What distinguishes malignant jaundice from jaundice caused by gallstones is its typical progression. It tends to be painless, gradual, and unrelenting rather than episodic. Gallstone obstruction is usually accompanied by colicky pain. Malignant obstruction often is not. This distinction is not absolute, but it's clinically important enough that painless progressive jaundice in an adult over 50 is treated as a cancer until proven otherwise. Jaundice also signals a degree of biliary obstruction that, if left unaddressed, can progress to cholangitis, a serious bile duct infection, making it not just a diagnostic flag, but an urgent management concern in its own right. 10. New-onset diabetes in adults without risk factors. The pancreas is the master regulator of blood sugar through its production of insulin from the beta cells of the islets of Langerhans. When a tumor invades or destroys enough of this islet tissue, or when it produces factors that impair insulin secretion and action, glucose regulation fails. The clinical presentation is new-onset diabetes mellitus in an adult who has no conventional risk factors for the disease. No obesity, no family history, no sedentary lifestyle that would explain it. This type of diabetes differs from typical type 2 diabetes. It often develops suddenly, progresses rapidly, and can be hard to control with standard treatments. Blood sugar levels may rise quickly, and a tumor-produced peptide called adrenomegaline may contribute by impairing beta cell function and increasing insulin resistance. The timing is important. Many people with pancreatic cancer develop new-onset diabetes 2 to 3 years before diagnosis. Because of this, unexplained diabetes in older adults, especially when accompanied by weight loss, may warrant pancreatic imaging. The key distinction is that new-onset diabetes in an overweight older adult with typical risk factors is often type 2 diabetes. In contrast, new-onset diabetes in a lean adult with no risk factors and unexplained weight loss is a warning sign that should prompt evaluation of the pancreas. Subscribe to the Human Health YouTube channel for more insights. If you found this content helpful, please like, share, and comment below.